Good afternoon and welcome. My name is Aaron Sizer, and I'm the Assistant Director of the Gating Institute for the Liberal Arts, which, with the Departments of Global Education and Kinesiology, is co-sponsoring this lecture. If you've come out today, you're one of many interested in the fast-growing field of global health. Our speaker this afternoon will share with us not only her own experience, but some of the incredible successes and ongoing challenges in this field today. Before we turn to that, I'd briefly mention that today's lecture is part of a new series on development organized by Cynthia Toms and the Office of Global Education. Cynthia has pulled together some great programming for this fall, and I would highlight two of these upcoming opportunities for you. First is a film screening and discussion. The film we'll watch together is Food Chains, which puts us inside the experience of those who grow and pick and transport our food, but themselves barely manage to survive with their families on starvation wages. That's a discussion on October 15th at 7 p.m. And then a couple of weeks later, Craig Bayerlein, a sociologist from the University of Notre Dame, will be here to discuss his work on immigration and faith-based efforts to redress humanitarian crises among immigrants on the Arizona-Sonora border. His talk will be on October 26th. So I'd commend those two opportunities to you. You can find those, as well as many other lectures this fall, in our schedule, which you can pick up on the way out the door today. Now I'd like to bring up Cynthia Toms, who will introduce our speaker this afternoon.
Hello and welcome. Wonderful to have such a great turnout today. And wonderful to welcome Dr. Jessica Evert to be with us. Dr. Jessica Evert straddles international education and the medical profession. She's a physician, and she's also the executive director of Child Family Health International, which is a nonprofit organization that provides community-based global health education to both students and institutions and fosters partnerships that empower local communities in more than 25 countries. Dr. Evert is a faculty member in the Department of Family and Community Medicine at the University of California in San Francisco, and she also helped to develop the Global Health Clinical Scholars Residency track there. Dr. Evert's research and advocacy focus on the ethics surrounding global education and engagement. She's also very involved in competency-based international education and examining health disparities. She's the author of many works, articles, and books. This is her most recent that I have here that I'm hoping she signs for me today. Developing Global Health Programs, a guidebook for medical and professional schools. It's in its second edition. For any of us out there who know it's hard enough to get one out, but then it requires a second edition, says something about its success. Dr. Evert is also a recipient of the Global Health Education Consortium's prestigious Christopher Krogh Award for her dedication to underserved populations at home and abroad. Perhaps more noteworthy, and these accomplishments obviously bear witness, that Jessica is a tireless and passionate advocate for improving the lives of people living in low-income communities who may not have access to equal health care. And she's also very passionate about training up the next generation of healthcare providers, that they have the knowledge and understanding to contribute to equality and access for all. I've gotten to know Jessica in professional networks where she is an incredible, as I mentioned, advocate, but also has the ability to translate the need for people sitting in this room to have a sense of how to go about this kind of work. She's a mother of 4, and we're just really thrilled to hear from her today. So if you will welcome Dr. Jessica Evert with me.
Thank you for that gracious introduction. So it's great to be here, and I want to thank the Departments of Kinesiology, International Education, and the Gating Institute for their support of my trip here today. It was, not a hardship to drive down the coast, so I'm grateful to be here. So I straddle a lot of different things. I have, I'm a physician. I specialize in family medicine, which is a broad-based specialty. And I also do hospice and palliative care that's towards the end of life or when quality of life becomes a priority. And then I do hospital-based medicine. But I'm here today wearing a couple hats. One is as Executive Director of Child Family Health International, and the other is as kind of a global health educator and activist and advocate. So CFHI GHI, and if you want to check out the URL, you can do that there, is an organization that young people can use to go abroad in a way that I hope to convince you is ethical, sustainable, and really gets to the root of the frontline experience in global health and the ethnographic understanding that we're really all trying to achieve when we're trying to understand other people's realities. And so check out that URL if you're interested. There's also some flyers that are going around. Today, as you heard, we're going to talk about pearls and perils of global health. And the first pearl we're going to start off with is don't take definitions for granted. And you probably know the person sitting next to you, but I'm going to ask one of you to read the definition, the top definition there on the slide, or if you're at home, go ahead and read that slide. The top definition was put forth by a group of leaders from the Consortium of Universities for Global Health, whom I work with, all full disclosure. And at the same meeting where that consensus definition was put forth, another definition was put forth. So what I'm going to describe to you in the next hour is going to be some ways that we can get to appreciate why someone would say the second definition, while also appreciating the goals, as someone said, and the ambitions that we have as a global health community, and that includes, I think, all of us in this room and many more. The second pearl I want to convince you of is that to understand global health, you need to get out of the hospital. Why do I say that? Many people think, when they think of global health, the image that comes up for them may be, an IV pole or hospital beds lined up, or a clinic and a doctor, or a nurse and a healthcare worker in a clinical setting. So what determines whether people live or die to the average life expectancy within their reference population? So one researcher, and he's fairly well respected for this estimation, has estimated that what happens in clinics and hospitals is about 10% deterministic when it comes to whether you live to the lifespan that you should, based on probability, versus not. And so what's really important when we think about health, whether we're talking about health domestically, health internationally, or global health, which is really encompassing both those things, is remembering that as scholars, as advocates, as faculty, as anyone who wants to know more and understand or affect global health, we have to go far beyond hospitals and clinics. And we're really challenged by that other 90%, which you can see here. This is some of the best modeling we have. Behavioral patterns are about 40%, genetic predisposition 30%, social circumstances 15%, and environmental exposure is 5%. And this study was done mainly in high-income settings. So when you're in low and middle-income settings where people have less money and less access to basic needs, some of those pieces outside the clinical realm are even more influential. And that also leads us to really appreciating the social model of health. Has anyone heard of the social model of health? Some of you? Okay. So the social model of health really has us understand that we as individuals are within these kind of layer cakes of different things that are determining how well we're doing in life, well, whether we're healthy or not. And in the middle there you have, age, sex, the constitutional factors, the things that make up your biology and your body. But then on top of that, you have layers such as your individual lifestyle factors. Do you smoke? Do you drink? Do you drive really fast without your seatbelt on? All these things affect, whether your probability of living well, having disability, or even having disease. And then on top of that, you have social and community networks. So there's really good evidence that how connected we are to other people is actually very influential for our health. On top of that, you have the living and working conditions of your life, which are determined by, do you have a roof over your head? Do you have access to healthcare services? Do you have access to clean water? Do you have employment? If you do have employment, what are your working conditions like? Do you have access to education? If so, what level of education? And then on top, we have kind of the general socioeconomic standing of the geographic area, or however we define our locality, as well as environmental conditions, things like war and political strife are in there, things that often are outside the control of the nucleus of the individual person, but are still very deterministic for how well we're doing and how our health is. So when we look at global health, if you are attracted to any career in any of those spheres, you are interested in helping global health. So I say that because I know everyone in here has ambitions that are probably going in a lot of different directions, and just to recognize the relevancy of all these levels on what we call health, which is a term that has unfortunately been hijacked in many ways by medicine to be too narrow, I think. So what's a peril? So one of the perils in global health that I want to warn you about is don't fall for the something is better than nothing myth. And what do I mean by that? This is a street in Nicaragua, and I was approached a few years ago by a group of students because their school was a little concerned about what they were doing in Nicaragua. They were first-year medical students, which is the first year of medical school out of 4 years. They were going to Nicaragua with a faculty member from their school, and they were setting up a temporary clinic and giving out medications that they brought and doing a lot of things. And the school was a little concerned, and they came to me and said, but we were the only people providing healthcare in this area. And I said, oh, you were? Really? Okay, how do you know that? Well, the faculty member told us that. And when I looked into it, there was actually over 280 health posts in that local geography. So when we think about that, just recognizing that often our interpretation of reality may not be reality, and sometimes things are not actually nothing. And what happens when we think that nothing is happening is we load our suitcases up with sometimes expired drugs, sometimes drugs that are in English, sometimes drugs that have side effects that we're not accounting for, and other equipment in very well-intended ways. But what we call duffel bag medicine in healthcare is when we kind of try and put all this stuff in a bag, take it somewhere, do something really quick, and then leave and hope that it improves the health of people. To better serve global health, what we need to recognize is sometimes when we see nothing, there's actually quite a bit happening, but it's happening in a way that's very unfamiliar to us. So on this slide, you can see on the left-hand side pictures of healthcare that's happening in Latin America mainly. And on the right, you see pictures of healthcare in the US. Well, as you can see, in the US, when you have a clinic, there's a big sign, it's real pretty, the building's made of brick or rock or stone, and it's got fancy windows. And in many other places, healthcare are health promoters going out to survey health status or to provide primary care. They're clinics that may or may not be very well marked or may or may not be very pretty. And so often what we may drive by without even noticing existing often does exist. So just remembering that our interpretation of what's happening and how we contribute to that is often due to our frame of reference. And it's very easy to make this mistake and see nothing happening when there's quite a bit happening. And one of the things that leads us to do is sometimes practice or do things that are beyond our level of training. And this is my favorite authoritarian text, The Onion. And they had this spoof about a year ago. And it says, new Doctors Without Licenses program provides incompetent medical care to refugees. And the picture is even funnier. But this is actually based on a true story, okay? This is based on a true problem that's existing right now, which is very well-intended people of all ages and disciplines going abroad mainly to clinical settings in my domain, but to other settings too, trying to help, but really doing so in a way that provides substandard care for vulnerable and often impoverished populations. And so really thinking about the onus to understand the local reality in a way that is getting outside of our own perspective to do that. In addition, this is becoming increasingly important for getting into medical, dental, and other health profession school. So if you have an interest in medical, dental, or health profession schools, thinking about the global health activities you engage in as an undergrad or prior to admission is really important because it's increasingly being scrutinized. So when you're going to be interviewed, it's not just you went abroad, it's what did you do when you were abroad and how was that thoughtful and respectful of professional disciplines and scope of practice. This is a resolution by the ADA, the American Dental Association, and it's the first to reach down into pre-dental students and say that even when you're pre-dental, you have to adhere to the code of conduct, professionalism, and scope of practice as if you were already in dental school. And so that's really powerful for us because I'm sure many of you would like to go abroad and think about how you can do so to both protect patients as well as protect your own reputation. We also have really good guidelines from the Department of Justice and also in the healthcare literature. So this is really everywhere, but not a lot of students have heard about it, and even faculty sometimes are unaware of these standards. One tool I'm just going to point out, this is a bit of a pearl, is the Global Ambassadors for Patient Safety. This is an open source module from University of Minnesota. And you can go on, you can do the modules, and then you take an oath of patient safety. And this oath of patient safety can be a really helpful reminder for you and for anyone you're working with if you're in country or in an underserved setting in our own backyard, to make sure you're adhering to patient safety, professionalism, best practices. And then Atlantis Project, which is an organization that facilitates students getting shadowing experiences in healthcare in Europe. This is a onesie that their son had, but I think it is just, it's very appropriate. So his onesie says, protect the vulnerable, only observe while shadowing abroad. So when you're in healthcare clinical settings where you have to have licensure and there's legal and patient care ramifications for what you're doing, just remembering that if you can't do it here, you shouldn't be doing it there. And trying to go abroad to preempt your experience level is unethical, it's unsafe, and it's only perpetuating the disparities that underlie global health issues to begin with. So I'll tell you a little bit more how you can be impactful, because I don't want to be a complete downer. In the meantime, a pearl that I want to share with you is, don't think that you have to go over there to contribute to global health. So global health, as we talked about in the first definition, isn't just over there, it's everywhere. And it's about eliminating health disparities at its root. And one of the more influential institutions in doing that worldwide is actually the United States. So this is the Development Assistance Committee funding. The DAC is kind of the overarching assistance organization for all countries. And you can see this data is from 2009, but it stays true today that the U.S. is by far one of the largest funders of international aid, particularly in the realm of healthcare and in other settings. And this is U.S. government spending. And then this is a graph showing you U.S. non-governmental spending. So one, it's been going up steadily through the years. So this graph is from 1990 to 2007. It's been increasing, and it's even increased now, today. But it's also a huge amount of money. So this was $5 billion in 2007. So you can actually affect global health without leaving your laptop or your desk or your bed or wherever you do your best writing, thinking, and or social media posts. And so I'm going to share with you a few ways that you can do that. So one is by advocating in a very kind of grassroots sense. This is White Coats for Black Lives. These are residents and medical students that work with me at the county hospital in San Francisco. So everyone on the team wears a Black Lives Matter pin as we round through the hospital. They had a sit-in, a lie-in really, where they all laid down in their white coats, blocking the entrance to the hospital. So there are certain peaceful demonstrations, and when you're in empowered positions such as physicians, this can often mean a lot for speaking out and just not being complicit in injustices. There's also writing. So if you're a good writer, letters to the editor are worth getting good at. So you can really affect policy and be a thought leader through writing, whether it's in the newspaper, in social media, blogging, or other avenues. And in addition to advocating for things that are happening globally or internationally, there's a lot of work we have to do in our own backyard. So this is some health disparity data, and on the x-axis I have different countries, but I also have GDP. So Cuba's GDP is about $3,600 per capita. That means how much money on average each person in Cuba gets or has per year. The US, when this data was done, was $43,000. And you can see there, this is infant mortality data. And if you look at Cuba, it was 5.8 per 1,000 live births. That's how infant mortality is measured. And when you look at U.S., white or non-Hispanic or even Hispanic, looks like we're doing all right, 5.65 and 5.7. But when you stratify the data for race even further, you can see that the U.S. Black infant mortality data is more than twice that of Cuba, despite the gap in GDP, and certainly much, much worse than U.S. non-Hispanic, white, and Hispanic. And so we have a lot of work to do to providing adequate health care and adequate lives for many, many people in our own backyard. And so the same values that underlie global health can also underlie a career or a passion for social justice at home. The third pearl I want to share with you is that if you do decide to go abroad, to do so in a way that builds impact through a partnership with longitudinal engagement and long-term view of impacts. And I'm going to talk a little bit of why that's important, and I'm going to use Child Family Health International as an example. So Child Family Health International, as I said, we run about 30 global health programs in 10 countries, and they focus on strengths. So I want to show you, as the future leaders, I want you to show you how well many places around the world are doing towards achieving global health with their own capacity, their own passion, sometimes with outside resources, often with their own resources. So in Mexico, you can examine the universal healthcare system, where there's 4 insurance schemes, and you can see how universal healthcare is provided to the entire population while also understanding the health disparities that still underlie people based on their employment status and their tax-paying status. In Ecuador, you can understand about sexual health rights. Sexual health is a human right. So sexual health was actually guaranteed in Ecuador's constitution, and it was the first Latin American country to explicitly guarantee sexual health rights. It's actually in their constitution. And so you can see how that was done in a 99.9% Catholic country and then trickles down to practice and be a part of the rollout of sexual health as a human right in that context. In India, students and trainees work with the WHO Collaborating Center for Palliative Care and Hospice, learning how in India they deliver palliative care and pain control without using morphine, which is basically the only drug we use here, because morphine is essentially illegal because it's so highly regulated. So it's really about understanding the strengths, because when we understand the strengths, we can help build on them, and that tends to be a much more sustainable approach to international development. In addition, when you work with an organization, and whether it's CFHI or another, there's many, many great organizations to look into, but when you work with an organization, they become kind of the conduit for your long-term impact. So back to the picture of the infant with the onesie saying only observe in clinical settings. Obviously, when you're not licensed and you don't have the appropriate expertise in that local context, even if you're licensed elsewhere, I'm licensed in the US to provide a variety of medical care, but I can't just pick myself up and be and have the same expertise in a different context. Different medicines, different tools, different language, different culture, different burden of disease. There's a lot of reasons, and when we're students, those reasons are even greater. So we have to embed ourselves in organizations that we can assist and work with, but are also working on our behalf to make sure that we have a sustainable impact that's positive and empowering. And that's where this intermediate organization comes in. So CFHI only places students in local healthcare systems. So there's kind of 2 models of engagement internationally with participating in healthcare. One is called the brigade model, and that's where you're kind of popping in, setting up a temporary infrastructure of some sort, and delivering clinical care. The other is called the integrated model, and that's where you're integrating yourself into existing healthcare systems. And these 2 types of programs have been compared side to side, and what happens when you integrate into existing healthcare systems is that you, 1, learn about healthcare systems, which happen to be fairly important in global health. But number 2, you learn about seeing patients over time with the disease process. So if the patient has diabetes, it's great if they can pop into your tent clinic and check their blood sugar, but diabetes is a disease that needs to be monitored and treated over time. So what you really want to learn is how it looks, on day 1, on year 2, in year 5, in year 10. And you can only get that continuity if you're in an existing healthcare system that is operating on a continuous basis. It also allows you to learn a lot more about the intersections of public health and clinical medicine. And public health, which is also geared towards population health, or is a synonym of population health, is really, really important, especially where resources are extremely limited. And that's because population health or public health tends to be much more cost effective than clinical medicine. So those are just a few of the reasons why to think about asking whether or not you'll be in an existing healthcare system, and thinking about how being in an existing healthcare system is developing your capacity, your competency, and your ability to engage and understand global health. So I can have Cynthia send this out afterwards, but I have kind of a little bit of a cheat sheet for how to examine an international opportunity and questions to ask. So some of these questions seem very basic, but it can sometimes, because we get really excited, which happened to me when I was looking at international opportunities too. Some of the basic questions maybe don't come to the forefront of our minds, such as like, what is your role when you're abroad? And what safety procedures and insurance and incident management is in place? If you're paying fees, what kind of transparency is there around those fees? Where are they going? Are the people that they're going to being audited, so you know that there's honesty in the financial practices? Does the organization have a code of ethics? What type of institutions is it affiliated with? Is it governmental, non-governmental, secular, faith-based? Because you may be looking for a certain type of endorsement that you may or may not have. When you are choosing to go abroad with a certain organization, you are speaking with your feet in many ways. That means that you are endorsing what the greater organization believes in. So you need to do your homework and make sure that you believe in what they believe in. So pearl number 4, Ebola is as much a symptom as it is a disease. So how many of you heard about Ebola in the news in the last couple of years? Right, most of us. Okay, so Ebola is what's called a filovirus, and it causes a hemorrhagic fever. So it causes bleeding out of a lot of orifices because it breaks down our ability for our blood to clot and the clotting factors and platelets and other things. And so it's a pretty horrendous death. But someone who was very close to this because he was working in Malawi and Liberia before all this happened, Paul Farmer, who's a MD anthropologist, PhD, he said this isn't a natural disaster, this is the terrorism of poverty. I'm going to tell you a little bit about why he said that. The first is that when you have poverty over time, you don't get a functioning healthcare system. And what Dr. Farmer was saying in response to Ebola, and Bill Gates even says it, is that they need stuff, staff, space, and systems. Okay, so that's healthcare system strengthening and building. Traditionally, all those donors that we saw in those graphs that I showed you, they often have been supporting things like actual vaccines, medications, what we call vertical programs that focus on one disease, such as PEPFAR, which focuses on HIV. So traditionally, donor interest and focus has been on vertical, disease-specific or medication-specific aid. What we learned from Ebola, and what many of us have known for a long time, is that that's not sufficient even for an infectious disease outbreak. You actually need a health system to fight outbreaks as well as to provide health care across the board. And healthcare systems have a variety of different pieces to them, but one of the 2 key features is people that know what they're doing and places where those people can do what they know to do. So let's just consider this graphically for a minute. This is our world on geography. So this is as accurate as possible geographic mapping of the world. And this is our world on infant mortality. This is the world on the number of physicians and nurses follow. So there's a mismatch, and that's one of the big concerns with health systems development, is that we have a mismatch between where we have the burden of disease, which means the most people sick, and where we have the people that can treat that disease. So here's it broken down for those of you that appreciate statistics. So in the Americas, there's 14% of the world's population and 10% of the global burden of disease, 42% of the world's healthcare workers, and greater than 50% of the entire world's healthcare expenditures. Sub-Saharan Africa, which you saw both shrink and get bigger on both of those slides, has 11% of the world's population, 25% of the world's global burden of disease, 3% of the world's healthcare workers, and less than 1% of the global expenditures on health. So this is a huge problem, and there's a lot of efforts to curb it, and it's not only because of things like Ebola, but it's actually because what is making people sick in the world is changing. And this is a graph showing you the burden of disease. So this is global mortality. Mortality means dying. Projections for selected causes from 2004 to 2030. So what's increasing cancers, ischemic heart disease, and stroke? All those burdens of disease require a pretty strong healthcare system to deal with. And the number one cause of disease of adults worldwide, regardless of where you're at, is what? Anyone know? It's heart disease. It's not HIV, it's not malaria, it's not even perinatal disease, it's heart disease. And that requires a really strong healthcare system because it's a chronic disease that requires ongoing management and early detection. So how is Global Health answering this? Well, Global Health is answering this through an initiative called Global Health 2035. And I'm going to talk to you just briefly about it. It was based on a Lancet commission, and it's basically a new approach to how to build healthcare systems and to measure whether we're having the impacts we need to have. So what they're calling the Grand Convergence targets are 1684. So the goal is that under 5 deaths per 1,000 live births will be 16. So 16 deaths per 1,000 live births. The annual AIDS deaths per 100,000 population will be 8. And the annual TB deaths per 100,000 population will be 4. So 1684. And how are they going to do this? There's a few different things they suggest, but one of the health systems contributors is actually building out what they call progressive universalism. So this is a fairly complicated illustration, but what it is it's a package. The blue area is a package of essential medications and covered healthcare services. And as and they focus on the most cost-effective and least costly interventions that affect the most impoverished parts of population. So you have this kind of essential covered set of healthcare initiatives. And then as your country grows economically in other ways, you can expand out the coverage that is provided under universal healthcare. And universal healthcare is generally healthcare that is government funded, meaning that everyone has a right to health and there is some way that everyone gets coverage. That's not exactly what we have in our country, or really not what we have in our country. We're moving towards that in some ways through a private, largely privatized model. But this generally, what they're talking about is government-funded health systems development and building. And so this is really what is thought to be necessary for achieving the global health gains and reducing the burden of disease for both NCDs, which are called non-communicable diseases like heart disease, stroke, diabetes, and even HIV and communicable diseases. So anyone who's interested in global health, you can go to the Global Health 2035 website and learn more about this. Another key piece of this initiative is the use of policy and taxation to influence health. So really thinking about how to disincentivize human behavior through taxation and increased cost of things. And this can be controversial, but in the global sphere, really taxing tobacco to limit the use of it is very well accepted. And the World Health Organization and the United Nations both have tobacco control frameworks that endorse this. So we're going to have some Q&A, but I just want to leave you with kind of an oath that really speaks to me, and it may or may not speak to you. It's called Carl Taylor's free version of the Hippocratic Oath. And Carl Taylor is one of the forefathers of global health. He developed the International Health Department at Johns Hopkins University. And he said this: I will share the science and art by precept, by demonstration, and by every mode of teaching with other physicians, regardless of their national origin. I will try to help secure for the physicians in each country the esteem of their own people, and through collaborative work see that they get full credit. I will strive to eliminate source of disease everywhere in the world and not merely set up barriers to the spread of disease in my own people. I will work for understanding of the diverse causes of diseases, including social, economic, and environmental. I will promote the well-being of mankind in all its aspects, not merely the bodily, with sympathy and consideration for a people's culture and beliefs. I will strive to prevent painful and untimely death and also help parents to achieve a family size conforming to their desires and to their ability to care for their children. In my concern with whole communities, I will never forget the needs of its individual members. I can provide a copy of this presentation, but this is something that does cause me to reflect and keep me a little bit on point. The Hippocratic Oath is an oath that generally you take when you graduate from medical school. You could replace the word physician with physical therapist, or with nurse, or with lawyer, or with social worker, or with accountant. You can really, a lot of the values and principles that are captured here are very translatable to other disciplines. So feel free to substitute the word physician for where you see yourself in the future. I'm going to end by just saying that I hope I have proven to you that contributing to sustainably developing and improving global health is a stepping stone process, both as, for us as individuals as well as for us engaged as a global community. And I'll just leave you with CFHI's tagline, which is "Let the world change you." And I think we'll open up for questions.